Welcome to A&A Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Today, we'll discuss an interesting current debate in vascular neurology. Should we keep using the term transient ischemic attack, or TIA? The term TIA has been used to describe temporary neurologic symptoms from brain ischemia, and it's been around since the 1970s, not long before the first MRI scans were performed on human patients. But with growing knowledge about cerebral ischemia and advances in stroke imaging, several people, including our guest today, feel it's time to retire the term. Our guest, Dr. Clay Johnston, is professor in the Department of Neurology at Dell Medical School of the University of Texas at Austin, and recently wrote a JAMA viewpoint about this issue. He'll be interviewed by A&A Education Innovation Committee Chair and neurohospitalist at UCSF, Dr. Megan Richie. Here's Megan.
Welcome to you. We're so delighted to have you here on the podcast.
Thank you, Megan. It's a pleasure to be here.
So could you briefly describe the meaning and the history of the term transient ischemic attack, or TIA?
Yeah, so transient ischemic attack was first defined, at least formally, in the 1970s, and it was designed to describe these episodes of neurological symptoms, stroke-like symptoms, that then went away. And the thought was that these were due to ischemia in the brain that then resolved. So transient ischemic attacks. And you had to have a duration because, that it could go away in seconds or minutes or whatever. And so arbitrarily, they decided on 24 hours. And that stuck for a long time. Then that was questioned more recently, now going back, 10, 15, 20 years, with the realization that a bunch of these folks had infarctions on CTs and MRs. The thought was, okay, well, they've got these infarctions and we're kind of poo-pooing them when we're calling them TIAs. Brain got killed here, so let's call those that have infarctions stroke. And let's try to get away from the 24-hour definition. And so that's the newer definition that was pushed by the AHA. It's used pretty widely. In other parts of the world, not as much because they don't have reliable imaging. So they don't have a way of differentiating TIA and stroke using that part of the definition. And so particularly in developing parts of the world, they haven't really adopted the new definition. They're still using a symptomatic one. But really Europe, China, US, South America, Central America, they all are mostly moving towards this newer tissue-based definition.
Thank you for the history. So with all the decades of experience that we've had with this term TIA, what's been working well? What do you think are some of the advantages of this term?
Well, it has allowed us to draw attention to these folks who don't have residual problems from brain ischemia, and to say, gosh, this is an important category. What happens to this group of people? We used to poo-poo it. We discovered, gosh, bad things are happening to these folks, and we need to do something about it. So the advantage is it's over time, we've been able to educate clinicians, to a lesser extent, the public, to say, even if your stroke symptoms go away, something serious has happened, and you need to go and be seen immediately.
Following up on that, what have we learned about the existence of permanent tissue injury after a TIA?
Well, what we discovered is that even if you look at CT scans, that a bunch of folks with transient symptoms, so transient stroke symptoms, will have infarction. And as we've now used MRI more, we realize that's maybe half of those with transient symptoms. And with higher powered MRIs, more and more Tesla, we're detecting more and more. So we're discovering that infarction is fairly frequent in the traditional diagnosis of TIA, which was based on time alone. And with the new definitions of TIA, we're now calling those ones with transient symptoms who have infarction, we're calling those strokes, and we're not calling them TIAs. So as the as we're discovering more and more infarction in people with transient symptoms, the question becomes, well, if we just had more and more sensitive studies, MR or ultimately a biomarker, wouldn't brain injury be found in pretty much all folks with transient ischemia? Any ischemia is going to be bad for the brain, and we'd likely find some evidence of that. And it raises a question about whether we have basically another arbitrary line in how we've distinguished TIAs from strokes. Before, the arbitrary line was related to time. Now the arbitrary line is whether we have sensitive enough imaging or whether we've even done the imaging, right? Whether we did an MRI scan in a patient and whether we're just calling that thing a stroke or a TIA. And all of that work is probably pretty irrelevant.
It's definitely interesting to realize that the word transient in the phrase TIA may really not be accurate when you think about what's actually there on an MRI scan that's sensitive enough to pick up ischemia. Is there anything else that you think might be improved upon in the term TIA?
Yeah, I mean, I think we do have to acknowledge that TIA includes mimics. It always has. And based on the way it's traditionally been defined, it always will. And even stroke, what we call stroke, includes mimics. There's strokes that we call them strokes, without MRI changes that are mimics. And we should just acknowledge that that's happening as well. So I do think we need to somehow have a term that lets us say this could be a mimic. And there are lots of proposals for what that term could be. We don't have enough time to go into all of that. But you could say a possible stroke. If we got rid of TIA, it could be a possible stroke or a probable stroke. And I think that would be fine. That would communicate pretty clearly, hey, in this case, we're not 100% sure, but we're gonna act as though it is.
Well, then what do you think about the relatively commonly used alternative term of mini stroke? Is that any better?
It's funny. I have disliked this term because of the use mini. Mini suggests just don't worry about it. It's just a mini thing. And these are events that people really do need to worry about, but they are mild strokes. And I would be comfortable with mild strokes or small strokes, or, small suggests you're actually seeing the infarction. So I would just say, mild strokes or minor strokes. I think that mild and minor, still you could say you don't need to worry about it, but I do think we got to acknowledge from the patient's perspective, not having symptoms, they don't want to appear like their parents who had some major deficit associated with their event.
I really like how you're describing how patients might respond to a term like mini stroke. I'm wondering, in your experience, how have patients responded to the more classic term of TIA?
I think that, having focused my career on TIA, I think most patients don't know what the hell it is. It's 3 letters. They don't know what the word ischemia is. I think we've clouded things by introducing TIA. And then people do know what a stroke is, or at least they have a better sense of it. Obviously, they get that mixed up too with with heart attack. But at least there's a great sense of, like being struck down, that's something they don't want, that they need to worry about. And they've seen others with the effects of it. So I worry, we spend a lot of energy telling people TIAs are this, and that you need to worry about them and take them seriously. I think it would just be easier to say, look, stroke is serious. Stroke symptoms may get better. And may even go away. The symptoms that you feel may go away. You're not out of the woods. That's still an urgent event. You need to be cared for. So that's the rephrasing that I think will be more useful for the public health messaging that's required around this term.
So earlier, Clay, you brought up how stroke by necessity also comes along with the differential diagnosis of stroke mimics. And so sometimes patients come in with a transient neurologic event that could be ischemic, and a clinician might obtain an MRI. And if there isn't a stroke there, then they end up having to make a clinical judgment about whether or not they feel that the event was ischemic or a stroke mimic. So in these situations, how would you counsel a clinician to proceed?
It requires clinical judgment for sure. But this is really why we developed the ABCD squared score, is to make it easier for folks to at least have something they could hang their hat on. I mean, it's not a perfect score at all. That's why clinical judgment is so important. But really the way that score is working, I believe, and based on a number of different studies, is by telling us who had a real ischemic event. Those are the ones you care about, because those are the ones where you can prevent the event that happens in follow-up. And that score still works even in those without infarction. So I think that's helpful, but it's basically, judgment. Is this real or not? I do think people should think more deeply about what the mimic could be and to address that as well. But you're going to make more mistakes by assuming that if there's no infarction there, it's a mimic, than by assuming that if there's no infarction there, it really was an ischemic event and requires aggressive treatment with secondary prevention. And that's the other thing, right? We have ways to treat TIAs now. You call them mild strokes or stroke without evidence of infarction or whatever you want to use for it. We have meds that work for that and that work pretty well that people should be on. So we don't want to pull those back. They're relatively safe medications. They're not used for very long. We don't want to pull those back just because there's a possibility that an event is a mimic.
So what do you see as areas of future research that would help better inform how we should use, or perhaps should change, the term TIA?
Yeah, so there are a couple of areas that I think are important. So one is there are a number of groups, they've been working on this for years, looking for biomarkers of acute brain injury. The one that we talk about a lot in our opinion piece is imaging, right? CT and then MRI. But we'll have blood biomarkers. They're being developed now and being tested. And I mean, I'm confident that those are going to, that we're going to have that troponin of the brain at some point. And I think that's going to be critical, because I think those without any troponin of the brain leakage, my guess is we're going to find a group at very low risk for subsequent events, because it's mostly mimics, if not all. So I think that's going to be the most compelling research that we see that drives this term. The other is just to recognize that, yes, as we talked about, there are plenty of follow-up strokes in the short term after patients have these events. And we need, even with the advances that we've had in recent randomized trials, there's plenty of room for improvement. So we need to be testing new agents in that setting. And there are several, too, that are getting teed up in phase 2 trials and should go to phase 3 trials soon. And so, I think that will be nice to see. But that's really part of the argument of bringing that together with minor stroke and even moderate stroke, because minor and moderate stroke patients will also be in those trials and benefit from those therapies. So getting people to think more in the same way about that whole array of events is really going to be helpful to getting quick adoption and common adoption for these new therapies.
Thank you so much for joining us. It was so marvelous to learn from you.
Sure. Well, thank you, Megan. This has been a pleasure.
That was Dr. Clay Johnston, professor in the Department of Neurology at Dell Medical School of the University of Texas at Austin, interviewed by ANA's Education Innovation Committee Chair, Dr. Megan Richie. To read Dr. Johnston's JAMA Viewpoint or to listen to past episodes of ANA Investigates, you can visit our website, myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Richie. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.